Really not sure.
Yeah, I'm not sure. I'm not sure because one strategy here, because I have to go to that superior part of the appendage again. Otherwise, we won't have enough length to place the 27, right? And let's see. I don't know. I don't know. Hopefully, it's gonna, because it's a big gap, right? So I'm not sure if with a 27 we will be able to cover. Yes.
Placing a second device would be an idea.
Second device? No. If this doesn't work, I would think about using a different kind of device. Maybe.
Yeah, that's a good idea. Yeah. Just the lobe and this device would do better.
Pedra, let's do the following. Take your time.
No, I'm okay.
Okay, we are going to show
how much time we have?
No, take your time. We're going to show the edit case that you have after a case, and you'll come back to you after the end of the edit case, okay?
But Majoni, we'll finish in a few minutes or less than a minute.
Okay. We'll wait.
No, I'm okay, Majoni, no problems at all. This is what we do, right? Every single day of our life. So it looks better. Let's see on echo big.
Back on the screen, please.
Screen, and let's use some contrast.
Yeah. Looks better.
And also I changed a little bit the angulation here. I didn't rotate counterclockwise the sheet in order to, let's see if it covers. Now I'm gonna inject some contrast here.
Oh, great. Looks great.
Yeah. So lucky us.
Congratulations.
Yeah, lucky us. It's better to be lucky than good. Libenso always said that. So let's go back to echo pictures so that we can.
It's looking nice.
Position.
Okay, here, let's start from 135 here. And we see now there's nothing left. And we see a well-positioned device. We see the compression. Let's put some color. I can't see any residual leak here. Let's move to 90 degrees. Again.
There's a bit of a shoulder, but not that ugly.
Yeah, here. And then let's go back to 45 degrees. Looks very nice. Yes, let's check with color again. It's okay. So for sure, this works better than the other one.
So I'm gonna do the tug test right now. So make the angel bigger on screen. Yes. And again, I'm gonna do this under Cine, pulling back my sheet. So I'm pulling the device, I'm pushing the device. Maybe it moved a little bit, so let's check again on echo.
Let's.
I don't think so.
So again, 45. Let's go to 0 degrees.
It's perfect. Definitely has a shoulder less than 1/3, correct, Simone?
Sorry?
As a shoulder is less than 1/3. Would you agree?
Yes. Yes. Let's see here. Yeah.
I think after the tug, the device moved a
little bit out of the
yeah, so I'm gonna recapture.
Yes.
And try to reposition.
Yes.
Move on. Petra, we have to move on for the next case, okay?
Okay, then when we are done here, we show you the final
The final result, okay?
Perfect.
Thank you.
Thank you.
Carlos. Then we will move forward to the next case, which is an edited case. I think, myself, I have to present it myself. No, it was a case performed at INCOR in a patient with a chronic kidney disease with Dr. Fabio Sandori Brito, Enrique Ribeiro, and I had the honor to be the guest operator. But I think that you should, okay.
We have the great pleasure to have Aníbal at INCOR doing this case. So the guest operator is also the guest presenter of the case.
Okay.
Please. We'll be here. And
I think that we can stop whenever the panel decides to make any comment or questions.
so very welcome to Lab 5 at INCOR. We have a great pleasure to be participating in LATAM VALVES this year, and I'm sure we have a great case, and we'll have a lot of discussion with the panel in this meeting. So for this case today, we have a great pleasure of having the guest operator from Argentina, from Rosario, our very good friend, Aníbal da Monte. Aníbal is for sure one of the pioneers of LAA closure in Latin America. I remember when I first started, Aníbal came to do proctoring for me more than 10 years ago. So Aníbal has a great experience with this procedure, so it's a great pleasure having you here with us. We also have here our two interventional fellows, the two structural fellows, by the way, and also we have Rodrigo helping us reading the images of echocardiography. So without further ado, I will ask Marcos to show us details of the case.
So this is a 64-year-old male patient with history of hypertension, diabetes, peripheral artery disease, permanent AFib, recurrent after ablation in 2018, previous stroke, liver disease virus-induced, chronic kidney disease on dialysis, currently on kidney transplant list, therefore not indicated for warfarin, with high ischemic and bleeding risk scores. The transesophageal echocardiogram shows an enlarged left atrium, the left atrial appendage with an orifice of 28 per 25 millimeters, lobe of 21 per 19 millimeters, and length of anchoring zone of 18 millimeters. Preserved ejection fraction without thrombus. The CT shows chicken wing morphology with extension of 32 millimeters and anchoring zone maximum diameter of 22 millimeters and perimeter derived diameter of 19 millimeters.
Thank you, Dr. Fabio. Thank you, Dr. Aníbal. It's a great pleasure for me to be here presenting you this case about the occlusion of the left atrial appendix. We're going to show you some images. We're going to start with the next plane imaging and 45 and 135 degrees, and you see there are absolutely no thrombus. We do some measurements in a specific angle, so we did measurements at 0 degrees that are displayed here, 45 degrees, 9 degrees, and 135 degrees. After that, we get the imaging in a 3D zoom of the left atrial appendix that can give us a more detailed expression of how there's a presentation of the left atrial appendix. We see here in INFAS that the orifice is absolutely oval, and we did the measurements in two places, in the orifice and the lobe. The orifice, the measurements are displayed here, 2.8 to 2.5 centimeters, and the lobe we got 1.90 centimeters. After that, we can show you how the left atrial appendix is displayed in 135 degrees. It looks like a more likely chicken wing presentation.
So as you saw, it's a young patient, very sick, several comorbidities, previous stroke, very high risk of bleeding. As you saw, the has bleed is 6, very high risk of stroke as well. The Schatz-Vasc score is 5. So it's a very sick patient that is also chronic renal failure, waiting to enter in the transplantation list.
First of all, I would like to thank you, Fabio, and all the team. It's my pleasure for me and a privilege to be here participating in this case of LAA closure. And for sure, this is a very particular patient because this is a young patient, but indeed a very high bleeding risk patient and a very high embolic risk patient with a lot of comorbidities. So I think that with the evidence we have available right now, this is the patient which would benefit from a mechanical procedure to avoid embolic events like a stroke or a systemic embolism, and to avoid the bleeding events related to his high bleeding risk. So I think let's go ahead.
So you think that this patient would be also a candidate for LAA occlusion, even if he was not entering the transplantation list, right?
Absolutely.
He has all the conditions to have an indication for LAA occlusion. So Aníbal, how is your practice? Do you do CT for all the patients, or you rely on TE, 3D echo? How do you manage these patients before the procedure?
Yeah, when we started the program, I think that we can stop here and ask this question to the panel. Would you like to comment, a short comment, each one of you, about how do you evaluate the patient? Which is the gold standard for you for patient evaluation regarding imaging for planning the procedure? Tanas, you want to start? From left to right.
We always do a CT in our patients.
I agree. I think it's important just to see better the morphology of the appendix, to choose the right device to close it.
The same. The pre-intervention always with CT, and we leave the ETE just for the intervention.
In my daily practice, I use the TE and angio. I not always have the CT ready for
So Aníbal, we just had a good example in the last live case that how important is for us to know exactly the anatomy of the appendage, to choose the correct device, the size of the device. Also, these small lobes that need to be covered. So I think that CT gives us information that no other method can give us. So in my opinion, if the patient doesn't have a contraindication, a formal contraindication for CT, I would do it for sure.
The same opinion. I think it's very important to plan, and it's easier to do the procedure.
Okay, let's move forward.
Aníbal, do you perform a pre-evaluation pre the procedure, or only during the procedure with TE or?
No. Just as we will discuss during the edited case, but unless the patient has, for instance, renal failure. In this case, the patient was renal failure on dialysis, so it was not a problem to use contrast for the multi-slide CT. unless the patient is advanced renal failure and we want to avoid contrast. I always, since 2017, I started evaluating all these patients and planning the procedure based on multi-slide CT. Back in late 2009, we evaluated the patients with TE, all the patients with TE. But as it happened with TAVI procedures, we later on get aware that there was some underestimation of the sizes with TE. If you talk about not having three-dimensional reconstruction of TE, but so we changed, I think in 2017, to evaluate almost all the patients with multi-slide CT because of the capabilities of multiplanar reconstruction and also volumetric imagings that can help, and by the way have been demonstrated that the size of the device that you are going to use is much more accurate when you define over multi-slide CT. So as in this case, we have seen that there is a very, very good correlation of the different sizes we want to have on advance with the multi-slide CT and with the TEs.
So now let's start the procedure. I'll do the transeptal puncture.
So for a good alignment, coaxial alignment of the delivery sheet, we should puncture it inferior and posterior.
So I think we are mid-fossa now, a little bit inferior, right? That's what we are aiming for. So can you show us the short axis? So now we see that we are a little bit more posterior, right? So I think it's a good position here. What do you think, Aníbal?
Absolutely agree.
So I'm doing the puncture, crossing to the left atrial. You see that the transeptal puncture is very safe when guided by TE. So another imaging tool that we can use for these procedures, Aníbal, is fusion. And here we have Heart Navigator from Philips that is the fusion of CT and fluoro. As you can see in our right-hand side, we see in blue the left atrium. In green, we see the appendage, the left atrial appendage. And we also see the pulmonary vein right on the left side of the LAA. Of course, you can see also the place where we crossed it, we did the transeptal puncture. And you see the catheter inside the left atrium as well. When we change the projection here, it moves. As you can see here, we can choose the best working view for us to do the procedure here. So you can, it's a very useful tool during this kind of procedures.
We have different devices available that can fit different anatomies. We are going to use a lumbar device, and the lumbar device fits very well very difficult anatomies, and by the way, it features a double sealing mechanism, which is very important, provided by the umbrella or lobe and the disc. We can do the procedure with a 10 French sheet, which is 4 French smaller than the usual sheets for other devices. There are usually 14 French. By the way, we can have a high percentage of patients with multi-lobes, and we have then smaller umbrellas with different diameters at the level of the disc. So it can adapt for a better sealing in very complex anatomies.
And to engage the LAA, what we usually do is we counterclock the catheter and pull it back. Of course, we can follow the Heart Navigator image, and as soon as we see a small jump, we'll probably be engaging the LAA.
We have a very safe position protected by the pigtail catheter, and this 10 French sheet is much easier to turn clockwise, or in this case counterclockwise. So we are in better position to start the deployment. It is very important to show that this has 8 hooks that will then turn inside, and this is very traumatic And this is the feature why we can recapture completely this device in case we don't want or don't like the position. This is covered by PTEF, and this is nitinol, so it is very conformability to the blood temperature, and this is the way we will start.
Hooks,
yeah.
they grab tissue like the trabeculus of the left atrial appendage and avoid embolization of the
For
device.
sure.
So
it helps the stabilization of the device, absolutely.
So now we keep exteriorizing the device. And this is the disc.
This is in this case, the 24 millimeters umbrella or lobe, and this is the 30 millimeters, 6 millimeters larger in diameter disc.
So we see that we are in a very good position, I think, for deploying the lobe, Aníbal.
Yeah, I think that we can start deploying the lobe, and as we showed outside, we start opening the umbrella of the device. You can see the hooks, the 8 hooks that are conforming to the LAA just below the angle of this chicken wing LAA. If you agree, Fabio?
I think we are fine here.
I think we are fine. And what we can see also is that the disc is well opposed to the Marshall ligament. So this is very important so as to avoid leaving a cul-de-sac where maybe in the future thrombus can form. So I think that the disc is concave.
So I think we got a very good position here. No flow.
I think this position is optimal because we have a good stability of the umbrella. We have a good separation between the umbrella and the disc, which seems that there is a stability of the lobe or umbrella in the case of this device. We have a coaxial position of the major axis of the device with the neck or landing zone of the LAA just before the curvature of the windsock morphology of this, this chicken wing morphology of this LAA, and we have a good concavity of the disc to the LAA. And you are showing by echocardiography that there is no flow. So I think
so
that...
we have all the criteria to consider it a very good deployment, right? So let's see the angio. I think it's very good. What do you think?
I agree absolutely, because as we were describing before the angiography, we have an excellent position, and by the way, even with the traction of the delivery cable, we see an excellent apposition of the disc to the orifice of the LAA, and we just see some very tiny penetration of contrast between the disc and the lobe, but not to the LAA.
Not to the LAA. That's
so
very important.
It is very important because we are injecting under pressure, but by echocardiography, in so many different views, there is no leakage inside. And this is very, very important because since 2019, we know that even small peri-device leak have some clinical relevance. So we have complete sealing in this case.
So you release the device.
Okay. As always, we go counterclockwise with the delivery cable. Sometimes it is 8 times.
So Rodrigo, now we have released the device. We do a final angio here. I think it's going to be nice to see the angiographic image. But while we prepare to do the angio, please show us what you see after the final release.
So Fabio, you see that the result is very good. It's an excellent case. You see that the top of the device is touching the Marshall ligament, and it absolutely closed the orifice of the left atrial appendix. We can see this in color, and we can really appreciate that there is absolutely no leak in 3D.
we are just in the injecting under manual pressure the contrast.
And we see by echo that there is zero flow
There
inside
is zero flow, and by the gold standard in every trial or registry is the evaluation of a peri-device leak by TEE. So we have to trust on TEE, we have no leak at all.
To finish the discussion, we have to decide here what we are going to do with this patient now regarding antithrombotic therapy.
So I think that in this case, the embolic risk of the patient is already fixed by the LAA closure, but the bleeding risk still remains. So I would not use even short time period of oral anticoagulation therapy. I would go for DAPT, maybe 45, 60 days or DAPT, and then I would test the patient with an imaging, either TEE or multi-slide CT, to see again.
To check for device-related thrombosis.
Yeah.
If there is good, if it's good, no thrombosis. Aspirin later?
Yeah, then we turn to single antiplatelet therapy, keeping it for 1 year, if it is possible, or at least 6 months, according to the patient risk. And then at 1 year, check again to avoid DRT or new leakage.
I think it was a fantastic demonstration of this lumbar device in a young patient with many comorbidities, with a very good indication for this procedure. And again, thank you so much for being with us here, flying from Argentina.
Thank you and the team.
And I'm sure it's going to be a fantastic meeting, LATAM Valves 2025.
So let's go to our lecture. Your lecture?
Or do you prefer to get back to Dante to see
yes,
if
we
they have
can
already
check
finished
if
the procedure?
They finished the procedure. In the meantime, the panel agree with the pharmacological therapeutic with DAPT for this patient? No anticoagulation? Okay. You agree?
Carlos?
Kaká. Hi guys.
We are ready to see how the procedure was performed.
The thing is, we are at a stake now because with the 27-millimeter device, can you put the angel on screen? Angel bigger, only angel. Angel. Só a geografia, não preciso dos três. Não split screen. Só grandão.
Pode ser com a gente.
Só.
Pode ser com o big screen. Pronto.
Now we have the 27, and I think this is the best position that we achieved, but there's a huge shoulder and with no contact whatsoever in the inferior portion of the appendage. Although it's covering that lobe, but I think almost 50%, I think more than 50% of that inferior portion is out of the appendage. I think this carries a high risk of embolization. So let's see the echo, and you can see this big shoulder on 3D, and there's a gap there. Echo.
Okay, this is real time. Let me show this, which one, Tito? Here. Yeah, so this is the, so this is a gap which is not covered, and this is the shoulder that we see. I can go real time now. Let's see here. Yes.
Martin,
So
what do you
real
think?
time 2G here.
What's the opinion of the panel to change for another device in this case to get a better result? It's going to be the appropriate strategy for you, Dr. Shamir?
This anatomy is not suitable, not perfectly suitable for a
Can
watchman
you speak
device.
up louder?
If you have a lobe and a disc device, you could cover this better, I think.
Petra, what are you going to do to...
I don't know, we are discussing if, I don't think a 24 placed towards the inferior portion of the left atrial appendage will cover everything, because on 130 degrees on echo, we measure about 25, the landing zone. So we could do that. We tried to reutilize the 24, but the catheter was damaged, so it was not possible. So we are discussing opening up another 24, give it a try, or not, or simply admit that this patient has an unfavorable anatomy due to the depth of the appendage for this kind of device. And then I think probably using a lumbrary, we don't know yet. Well, I would like to hear the expert's opinion.
Kaka, I think the 24, it was very compressed inside the superior lobe.
Yes.
If you pull more proximal, maybe you can open more and close. Sometimes I get this kind of the two lobes. When you compress inside the one lobe, you have more, like in this case, very compressed the
So what
device.
the panel thinks? Should I
Maybe
proceed with another
24 very more proximal, and maybe you can cover all appendage.
Okay.
Petra, it's a hard discussion, Martin, but I think, in my opinion, you're right. We discussed some minutes before to try another 24, but not in the upper lobe, but in inferior portion to
Yes. Before the division, the both lobes.
Okay. We have to go to the lecture, and we can return to you after the lecture of Dr. Aníbal, that will tell us about will new data change our practice? Dr. Aníbal, please.
Thank you, José.
Tentar outra 24.
Slides.
Vamos passar para a apresentação do Dr. Aníbal, por favor. Obrigado.
Well, okay, this is the presentation. I don't know what happened with the slide. Okay. Let's go again. So, stroke prevention in AF, will new data change our practice? Well, first of all, for young population here in the room, it's been a long journey since the first publication of the feasibility of LAA occlusion through a transcatheter approach by Horst Siever in 2001, and in 2009 we started in Latin America the first cases. So it has been a long journey up to now, and this journey has been justified because all of us know that anticoagulation, and since 2010 direct oral anticoagulation are the gold standard for the treatment and prevention of a stroke in atrial fibrillation patients. But if we pay attention to the Garfield registry with more than 50,000 patients, and we consider only LATAM patients, we see that 24% of patients are only taking aspirin, and 14% of patients are not taking any anticoagulant. So there is a huge work to perform. So this could be the agenda. I will go fast. LAA closure through versus DOACs, cardiac CT for planning, and we have discussed during the cases comparison between devices, current indications, and simulation training. Regarding the randomized trials, in the era of DOACs, all of us are aware of the Prague 17 trial, which was published in 2020, that randomized high bleeding risk patients and high cardioembolic risk patients to DOACs, mainly 95% apixaban or LAA occlusion with the Watchman or with the amulet device, and the non-inferiority hypothesis of LAA occlusion versus DOACs in this patient population was proved. There was no difference at all regarding any of the components of the composite endpoint, all-stroke TIA, cardiovascular death, clinical significant bleeding, and non-procedural clinically significant bleeding. But it was evident at the first publication that there was a difference with lower bleeding rates in the patients with LAA occlusion, even when the patients in the control group were taking the best possible oral anticoagulants. It is very interesting that in the second publication, at 4 years follow-up of the PRAC 17, again, there was a non-inferiority of LAA occlusion versus DOACs in terms of prevention of cardiovascular death, stroke, TIA, or bleeding, but regarding non-procedural clinical relevant bleeding, as long as time goes by, at 48 months, 4 years, there was a significant reduction in the rate of bleeding, major bleeding or clinically relevant bleeding in the group of patients that were allocated to LAA occlusion over the patients that were treated with DOACs. How does it translate into real-world practice? So we can pay attention to some registries, and this is very interesting, registry from Denmark that was published also in 2020, and they compare two groups according to a propensity score match, 1,000 patients LAA occlusion, 1,000 patients with DOACs, all of them high bleeding risk patients, all of them high stroke risk patients. And at 2 years follow-up, you see that the incidence of this composite event, ischemic stroke, major bleeding, and mortality has a 43% relative reduction in the patients that were allocated or treated with oral with LAA occlusion. And by the way, at 2 years, even in a so sophisticated a healthcare system like in Denmark, 60% of the patients have withdrawn the oral anticoagulations. So this is to take into account. And of course, there is a meta-analysis also published in 2020, including the patients from Protect AF, Prevail, PRAC 17, all showing that there is non-inferiority in terms of prevention of cardioembolic stroke, but there is a significant reduction in hemorrhagic stroke, cardiovascular mortality, all-cause mortality, and non-procedure related major bleeding. Moving forward, there are special populations like these patients with kidney disease and with advanced kidney disease, like the case before, and some very special population that is the patient that already in anticoagulations presents with a stroke. So there is no randomized trial regarding these patient populations, but there is a propensity score match study that was presented in 2022 in the European Society of Cardiology Congress, where the patients in green LAA group versus DOACs presented less recurrence rate of stroke than the patients that continued to oral anticoagulation therapy. More recently, last year, during the American Heart Association meeting, it was presented and published simultaneously in New England Journal of Medicine, the option trial that randomized 1,600 patients after a radio frequency ablation of atrial fibrillation to LAA occlusion with the Watchman Flex device or oral anticoagulation, 95% of the patients with DOACs. And again, this trial showed clearly that even in a population with less bleeding risk than in PRAC 17, the rate of major bleeding and no procedure-related clinically relevant bleeding was reduced in 56% at 18 months follow-up respect to the patients that were allocated to continue on oral anticoagulation with a non-inferiority in terms of prevention of cardioembolic stroke or systemic embolism or death from any cause. So there are many other trials ongoing, but I think that the more relevant are Catalyst and Champion AF with 3,000 patients in low bleeding risk populations that will give us further support to know if really LAA occlusion can move forward to a first strategy to prevent cardioembolic events in patients with non-valvular atrial fibrillation. Regarding CT planning, we have discussed it, but we know that there are several pitfalls and limitations, and we knew it when we started using multi-slide CT to plan TAVR procedures. So we want to have these multi-planar reconstructions that give us a different approach to the procedure itself. And it has been already published some years ago that the size of the device that you choose to close the LAA, whether it was an amulet device or a Watchman device, was much better when you decided on the size of the device based on multi-slide CT than based on TEE. And by the way, artificial intelligence can also help us. And there is emerging evidence that was presented at TCT in 2022 and published in 2023 from Ole de Bakker that shows that with these tools we can even improve the results of the procedures and decrease the total number of devices used in 15%, the total number of device repositionings in 50%, and the use of radiation and contrast medium in 25%. This is emerging evidence, but we have to take it into account. Of course, at the end of the day, what we pretend is to have this baseline multi-slide CT and this multi-slide CT at 45 days follow-up, whether we can see clearly in the coronal and sagittal view that the LAA is clearly closed without device-related thrombus, probably with an adequate endothelialization procedure and without any kind of leakage to the LAA. Comparison between devices, I will only mention the largest trial, which was the Amulet IDE trial, which allocated 1,800 patients, 900 to Amulet, 900 to Watchman. It had a primary safety endpoint that was already met. Amulet was as safe as a Watchman at 12 months follow-up, and as effectiveness primary endpoint at 18 months follow-up. And the Amulet again was non-inferior to Watchman device for the primary effectiveness composite endpoint at 18 months. There was a mechanistic endpoint also regarding the capability of a double sealing device against one single sealing device in terms of the residual jet less than 3 millimeters, and at this point it seemed that Amulet was superior, but we have to be honest that it was with the older generation of the Watchman device, the Watchman 2.5, and when we look at the results of the Pinnacle Flex trial with the Watchman Flex, which was used during the live case of Dr. Carlos Pedra, indeed the complete sealing at 12 months was 90%, pretty similar to the Amulet device in the Amulet IDE trial. So moving forward, what is important from this trial that whether you use a Watchman device or an Amulet device at 18 months, and pay attention to the lower part of this slide, those patients that had in red a peri-device leak less than 3 millimeters, and those patients with a peri-device leak of more than 3 millimeters, you can see that here there is a higher risk of ischemic stroke or systemic embolism in those patients with a leak more than 3 millimeters, and a significantly higher risk of stroke, systemic embolism, or cardiovascular death in these patients with larger leaks. So residual leaks can and should be avoided, but adequate patient planning with 3D imaging technique, either multi-slide CT or 3D TE, careful device selection based on LAA anatomic features, optimal procedure, TE or ICE, and angio assessment, and LAO technique optimization. And for the follow-up of either leaks or device-related thrombus, we have this consensus published in 2023 in JSCI that at 45 days, and at 1 year we should perform an imaging, either TE or multi-slide CT, to check that everything is going all right. Regarding indications, of course, and classically the indication has been on the right side, contraindication to oral anticoagulation, and on the left side, those patients should go for oral anticoagulation therapy that should receive DOACs. But in the middle, we have a very important group that are patients unwilling to take or unable to take oral anticoagulation, patients with individual specific constellations like stroke under warfarin or isolation of the LAA post-ablation, and those patients that have a high bleeding risk and should be discussed in an atrial fibrillation team. Regarding the guidelines, the more recent guidelines from the American College of Cardiology, American Heart Association, has moved forward one step to 2A indication for patients with high risk of cardioembolic stroke and patients with contraindication to oral anticoagulation, and to consider with a recommendation to be for patients with high cardioembolic risk of stroke, and it is considered a reasonable alternative to oral anticoagulation therapy. By the way, how does it translate again to clinical practice? And if we pay attention to the National Cardiovascular Data Registry, 2016 to 2018, let's get back, okay. Increased, which were the more important indications: increased of thromboembolic stroke risk, history of major bleeding, high for risk, which has to be considered in elderly population, labile international normalized ratio, patient preference, that is always very important, and non-compliance with anticoagulation. Of course, these categories are not mutually exclusive, and patients may contribute to many to different categories. The role of simulations, like we have enjoyed during these 3 days, this training village was all the time fully packed of people. Well, it is very important, because if this trend that Prague 17, that the option trial and the registries are showing is confirmed with Catalyst and Champion AF, we will need a larger number of interventional cardiologists and electrophysiologists performing these procedures. So again, simulation is the first step, and all of us know that simulators can help in training in transeptal puncture, in device position, in anatomies of different complexities, and even in simulation of the device position and sizing. So finally, and as conclusions, data from different surveys of patients with atrial fibrillation support the need for non-pharmacological approaches for stroke and systemic embolism prevention in non-valvular atrial fibrillation. A relevant bleeding risk remains with DOACs, which are also dependent on drug compliance. There is currently strong evidence from randomized trials with long-term follow-up and large registries that strongly support LAA closure as an alternative to oral anticoagulation, even in the era of direct oral anticoagulation. Clinical practice guidelines often lag behind clinical practice and fail to leap. New imaging technologies provide valuable information to optimize the planning and outcome of the procedure, as we have seen during these previous cases, and simulator training play a fundamental role in the education process in all the fields of structural intervention. Thank you very much.
Congratulations, Dr. Aníbal. Unfortunately, we are run out of time. No more time for questions. I'd like to thank our panelists, our colleagues, our physicians who performed the case, and the audience. Thank you very much for all.
Fábio, pergunta para ele se o Anthony... Yes. Tá pronto? Eu vou falar aqui, eu falo aqui. No. So last but not least, we're gonna do the last session of this amazing event with a very nice, topic on when structuralists face challenging situation. We're gonna do some changes to the initial program. As moderator with me, Dr. Rui Teles from Portugal is going to join in a couple of seconds. And also I would like to call Dr. Jorge Mayol, José Mariani Jr., Luis Antonio Ferreira Carvalho, Dr. Sushil is there. I'm not sure if Vinicius Daher is still there, please. And also Dr. Adam Greenbaum. Thank you for being with us. And we're going to start with a nice lecture from Dr. Sushil Kodali on approaches to prevent coronary obstruction in native involving VALVES, Basilica, Unicorn, Chimney, case-based lecture. Thank you, Dr. Sushil.
Thank you very much. I'm giving this lecture, but Dr. Adam Greenbaum's here, so he's probably could give this better, and he's also going to correct me on all the mistakes I made. So Adam, feel free to interrupt whenever I say something. So there's a lot of different, obviously, these are my disclosures. So, we understand that coronary obstruction is a rare event. It's less than 1%, but the problem is it's catastrophic when it occurs. And if you're not prepared for it, the mortalities are extremely high. But I think, thankfully, we've gotten better at understanding who's high risk. And patients with sort of, the standard risk factors, narrow STJ, low coronaries, bulky leaflets, heavy calcium, and narrow VTCs are at higher risk. The one thing I will say, we just have to be cautious, and not every patient should get a TAVI. So what is the best management of patients at high risk for coronary? If they're surgical and they're low risk, don't do leaflet modification for the sake of doing leaflet modification. A low-risk surgical patient, because there are other things that are going to impact that, right? They're at risk because they have no sinuses and everything else. And they're not going to get a great result. So prevention is good. Screening is the key. And so, surgery is always a good option in certain patients. And I think it's important to keep that in mind because we often lose sort of track of that. But there are patients that obviously are not surgical or very high risk where you're going to do a TAVI and you need to figure out how to manage it. And there's generally two approaches to managing it. One is the snorkel or chimney stenting. I think in lower volume centers, this has become the preferred approach for the most part because it's technically straightforward in most patients. You can use it in a lot of different settings, TAV and TAV with commissural malalignment, negative coronaries, narrow STJs to an extent. And, there's some advantages to the simplicity of it and being ready for it because you don't risk hemodynamic compromise. But it does require lifelong DAP. It makes coronary reaccess difficult. And if you're talking about someone that has coronary disease, that's an important issue. But I think there's advantages. Then obviously there's leaflet modification with either Basilica, Unicorn, and some other technologies that are coming. But it is technically challenging with use of off-the-shelf tools. There are dedicated tools coming, hopefully, but it is still challenging. That limits its use. And so if you have one case a year, you're never going to be comfortable with it. And so I think that's part of the challenge. But there's a dedicated device with shortcut in the US that make it simpler and hopefully more reproducible. But it's not appropriate in all anatomies, and we'll discuss that. And the balloon-assisted approach may be more effective, but it may come at increased procedural risk with embolic events and stroke. So it's important to keep that in mind. So just going through chimney stenting to start, basically you pre-wire the coronary and you put a wire and a stent. If you're worried about the left, you just put a wire down the LAD and you keep a stent there with a guide catheter. I typically use a guide catheter with side holes because I'll just pull that guide into the aorta and I'll do my aortogram through that guide catheter while the stent is there, so you don't need another access site. And so then you deploy the valve. And if there's obstruction, then you pull the stent back and you deploy the stent. Now, important to keep in mind, you're not stenting coronary disease, you're stenting a leaflet. So you need to pull back the stent far enough, and that's why you generally need longer stents, because you need enough, at least 50% in the left main LAD to anchor the stent, but you need enough hanging out so it's actually going to keep the leaflet away. And then if you need to post-dilate the valve, you're going to want to do a kissing balloon with the stent to make sure you don't crush the stent. So pretty straightforward, and I'll go through it. And the results from this is one registry, 60 patients, and 35 were preemptive, 25 had obstruction. There were 3 deaths, and these were all in patients that didn't have a upfront coronary protection wire in place. So they were trying to